I'm Callie Ackermann. I'm an orthoplasty surgeon, so I did fellowship training with a focus on hip and knee revision surgery. I think it's one of the few designs where you have a single radius on the femoral component, which necessitate very careful balancing of the medial collateral ligament, and that then allows you to have good ligament stability and balance, and allow the knee to be slightly looser on the lateral side from full extension to flexion, which then mimics the normal knee biomechanics, which then makes the knee feel more natural. And I think doing that and giving you that good stability right from day one, you put less pressure or tension on the patellofemoral mechanism, which then causes less pain. All my patients now seem to have dramatically less post-operative pain from day one. People immediately feel that their knee moves well, but they feel comfortable and safe to walk because the knee feels stable, just from the ball and socket design of the medial pivot knee. Medial pivot knee has the lowest revision rate and the better function and pain scores. And we know from this research and clinical work that the outcomes on the long term is as good or better as any other knees. And we now know that the function and the pain score are better as well. Dramatically better function and less pain. I think my wife is a very good example. She was a long-distance runner, and she had a stress fracture years ago from running on the left leg, and she ended up needing a hip replacement for arthritis and hip dysplasia. And about a year later, she had a knee replacement, and she could honestly say that the knee replacement was almost easier than the hip replacement. The pain was very similar, and she's a more complete person. She struggled with depression because she couldn't do the outdoor activities that she loved. She walks about 15 kilometers every day. She takes the dog for walks on the beach 2 or 3 times a day, and she doesn't have any more pain, and she feels that she functions as well as she did prior to having joint problems. My job normally at 2, 4 and 6 weeks was to tell my patients with knee replacements, don't worry, I know it's sore, what pain medication do you need? And now when I see the patients at 2 weeks, people don't use narcotic painkillers when they leave the hospital. And at 6 weeks, we more talk about function than pain. I think the medial pivot knee really complements the whole kinematic alignment principles, where you really try and, with the implants, reproduce what the patient had prior to the knee wearing out. And you don't have to guess, so you can feel if the ligament is appropriately tensioned, either not too loose or too tight, and you can very easily, by taking a little bit more bone away on the tibia side, be sure that it's properly balanced and that it clinically will work. I think I've been doing knee replacements now for close to 30 years, and in the last year I was really blown away as to how significantly my patients are doing better, and how I can be more assured that every knee that I do is going to work out. And I think we all strive to reduce the complications and those outliers that don't do well. And I truly believe that with this design and this technique, there isn't going to be outliers. Have a look at it. I think if you read and you look at the clinical outcomes and the patient's testimonies, I think it would be a very wise choice to consider this instead of a different knee. Oh, I see it as a blessing and a privilege. Mobility is extremely important, not just to keep healthy with your heart and lungs, but it's really important to keep your muscles healthy. I think if you have good muscles and mobility, it makes your chance for dementia less. It makes for a happier person. You get into the outdoors. So I think emotionally, socially, health-wise, it's really important to stay active and mobile. And when you have a sore, worn-out hip or knee, I think we now have reliable ways of helping people to go back to their normal activities.